Dr. Russ here with episode 4 of Let's Get Paid and Stay Out of Trouble. This one is taking notes. Episode 1, we talked about the good patient intake and having a compliant intake, all the information you need to have. Episode 2 was about treatment coding or diagnostic coding. Episode 3 was treatment coding, and now we're going to talk about actually note-taking. Not something that I learned well enough in chiropractic school. It took me, if I'm being honest, like 12 years in practice before I really had my files as good as they should be. And during that 12 years, fortunately, I didn't get in any trouble, but I could have, and I want to prevent that for you. You're watching this video because you want it to be good, and therefore I want it to be good for you too. So let's talk about how to make this right. Also, if you're watching this video, you probably know me. In case you don't, my name's Dr. David Russ. I'm a chiropractor. I practice in Portland, Oregon. What qualifies me to talk about this? I've been in practice for 25 years, and I've spent a lot of time doing file review and medical legal work. I never worked for an insurance company. I did volunteer work for the state board, and I have done some medical legal consulting for lawyers on personal injury and malpractice cases. So I've seen a lot of files, the good, the bad, the ugly. Let's make ours good because we want to get paid and stay out of trouble. And when it comes to getting paid, having good documentation is so important. Probably about 15% of my practice right now is motor vehicle, PIP. And in every single one of those cases, every single claim must be accompanied by treatment notes, which are read by a human as of this point. Probably before too long, it'll be read by an AI bot. But the point is, that file, that documentation needs to do a lot of different things for it to get me paid. It needs to describe what the patient's symptoms were, how those symptoms were related to the accident, what I did about it, and how what I did was related to the symptoms and therefore related to the accident. At the same time, all the diagnostic and treatment coding needs to be perfect. It needs to be right, or they're going to deny the claim or just not even respond to it at all. Now, like I said, I've never worked for an insurance company. I guess I'm proud of that. But the point is, I don't exactly know how things work over there, but I do know that they don't make money by paying me, and that they would rather not pay me, and that they will take the opportunity not to pay me any chance that they get. I think our whole system is crazy and super inefficient and kind of ridiculous, but this is the system we're working within. So we want to try to work within it as well as possible. I also know that when it comes to claims, and this is a subject for another video, every denial has to get followed up. Do not let them get away with a single one. You have to have a claims tracking software, and with software now it's way easier than it used to be, where you can see every claim that is outstanding, and either you or someone you delegate to or outsource to follows up on every single one. Don't let them get away with a single one. So these insurance claims reviewers are paid, not much, to look at your request for more care and find reasons to approve or deny. And if it's not totally approvable, it's going to be denied, and then your patient suffers, and then your business suffers. So if you are giving justifiable care, then you really ought to be documenting that so that you can deliver it and get paid for it. So we want to keep insurance reviewers in mind. We want to keep in mind that medical legal issues do arise. We don't like that it happens, but it does happen. Sometimes things go sideways. Communication goes sideways, patient's health goes sideways, or something about the treatment, there was a contraindication that was missed. It happens. Your file is your only defense in these situations. So having your file be complete and compliant and really spelling out what did and did not happen will really help anyone who is hired to defend you. If you read case studies from risk management, which is interesting reading, a little scary at times. So chiropractic malpractice companies will send you, if you're a malpractice policy holder, once a year they'll send you something in the email saying, read this case study of a chiropractor who got sued. And a lot of times it's like a scary story about a patient who came in with a disc and the chiropractor missed the disc and the patient got worse and sued the chiropractor. And they always say the chiropractor's notes were bad, so we were not able to defend the claim. That's kind of the point of that story. Your lawyer won't be able to help you if you have a bad file. They cannot make a file say something that it doesn't say. And then there's administrative trouble, and that's more trouble with your board, which we'll get into in another video. But we want to avoid these things. We want to protect ourselves against these things. That's the stay out of trouble part. We want to get paid and we want to stay out of trouble. And this is a good time to acknowledge that we're talking about the business side, and the business side is here to support the human side. So yes, we want to get paid. We need to pay our rent. We need to pay our bills. We want to have money to do the things we want to do. And we are in this because we love our fellow humans and we want to ease their suffering and ease the suffering on the earth, which really every little bit that you can do right now in this day and age is important. So let your file demonstrate to anyone who comes across it that you are a professional, that you are patient-centered, that you are diligent and disciplined, and let there be no doubt as to why you were there and what you did and what you did not do. Software right now will take care of a lot of the formatting for you. Back in the old days, we did the SOAP format when I was writing them out in pen and paper. There would be an S for subjective, an O for objective, an A for assessment, and a P for plan, and we had to write it out that way. So I got in that habit early on, and my treatment notes are still in the SOAP format, but it's not necessary to use the SOAP format. What is necessary is that all 4 of those elements minimum are in every patient visit. That every patient visit, somewhere in that documentation, there is a record of the patient's subjective status, your objective findings, your assessment, that is, what do you conclude from these objective findings and subjective findings, and plan, which is what are you going to do about it. So I don't care about the format, but I do care that all of those elements are in there. And on the first visit especially, there's going to be more, because on the first visit, that's when you really gather all the information about the patient's subjective. That's when you do the most intense and comprehensive exam. And that's when your assessment is really mostly taking place. And that is also probably when you're doing the most planning. So the first visit has more, and then all subsequent visits still have all 4 of those things, but probably just a less quantity of information. So let's talk about the subjective first. Let's start with the S and the patient's chief complaint and present illness. And we'll talk about a patient as if they just came in, and we have to get their chief complaint, present illness, family history, and health history. Now, some people like to do this on the paperwork. I like to do it a little bit on the paperwork, but I really want to do it in an interview with the patient. In 15 minutes discussing a problem with a patient, I can, like 90% of the time, know what is wrong with them, and the other 10% of the time know where they need to go to find out what is wrong with them. There is that 1% that I don't know, but I can tell so much more from talking to a patient. I would rather ask them sequences of questions, and my question is like a decision tree, and we can get right to the heart of it rather than give them 10 pages of an intake and then ask them those questions anyway. As a patient, I'm always kind of annoyed about that. So when I come to ask a patient about their chief complaint and present illness, I still use this mnemonic, LMNOPQRST, which I learned way back in the day. I still ask myself, do I have my LMNOPQRST before I'm ready to move on to the exam? So let's just talk through these in case no one ever told you about this. And you can fast forward if someone has. The L stands for location. Where does it hurt? And 99% of the time, people go to the doctor because something hurts. Mechanism is, how did it happen? And you want to be specific as you can. Some patients will say, well, I fell. Well, you say, fell doing what? Don't just say patient fell. Okay, let's move on. Well, what were you doing? How did you fall? Well, I fell while I was skiing. Okay, well, what happened? As chiropractors, well, I speak for myself. I want to know, how did you fall? How did these forces go through your body? That's going to inform my understanding of what might be injured and how. The compression, the shearing, the torsion, all these things are important. So then the patient says, well, I was skiing and I fell on my front and my legs went over and I kicked myself in the head. That's called scorpioning, and it looks like this. And I thought of that because this happened to a patient of mine once, and unfortunately she did not fracture her spine, but you can fracture a spine doing that. And living in the Pacific Northwest, there's a lot of skiers and snowboarders. So sometimes the patient doesn't know what happened, in which case you write, the patient cannot identify mechanism, which indicates to whoever's reading it, including potentially future you, that you asked the question. I asked the question and the answer was, I don't know, Dr. Russ. I don't know how this happened. It just happened. It's important to note that. It's important to note negative orthopedic tests. It's important to note negative findings as well as positive ones. We've done L, M, and now we're up to N, which is for new. Is this a new problem? This lets us know, is this acute? Is this subacute? Is this chronic? In general, acute issues are more likely to require urgent care. And a big question we need to answer as quickly as possible when a new patient or any patient comes in is, are you in the right place? Do you need to be in the emergency room? Do you need to be in the hospital? So when a person comes in and says they have, rib pain and, pain in the middle back, immediately I'm like, okay, cool, probably a rib, maybe an intercostal muscle, maybe a sprain of an intrinsic spinal muscle, but maybe it's the pancreas, maybe it's the gallbladder, maybe it's lung. How long has this been going on, right? Well, I've had this problem for 3 years on and off. Okay, that's less likely to be a life-threatening issue. It's not 100%, but I always want to know how long has this been going on. And tied into that is O, LMNO. O is for onset, and onset is not just is this new, but when did this start? In the case of the person who scorpioned while snowboarding, did this hurt immediately? Did it hurt 5 minutes later? Or did it take a couple of days for this pain to set in? Because that immediate pain is probably a more serious injury than the pain that took a couple of days to set in. Again, I say probably, and we're always wanting to correlate and layer and integrate any new information we get into what we already know. P is for provocative and palliative. What makes it better? What makes it worse? That's so interesting to know, and also often correlates to the type of tissue and the type of injury. Maybe this is a good idea for a more in-depth video on another day. The language you want to use is better with, or better while, and better after, or worse with, or worse while, or worse after. And there's a difference. Like if I see in my file worse while walking, foot pain worse while walking, I know that the actual walking hurts, right? Instead of worse after walking means it doesn't hurt while walking, but later it's fatigable. There's some stress and strain on the tissues that takes a little while to manifest in discomfort. That's a different type of situation than something that hurts with every step. Okay? The Q is for quality of pain, which often correlates to the type of tissue that is generating the pain. We know that nerve pain is going to be tingling or cause numbness or itching, or can be hot or shooting or spreading pain, whereas muscle aching and soreness is different, or a sharp pain in the shoulder versus a dull ache in the shoulder. So quality of pain, write it down in quotes as the patient describes it. Use their words, okay? R is for radiation and referral, also extremely useful in identifying the tissue of causation, where an SI joint will radiate and refer pain in a different pattern than a lumbosacral joint or than a sciatic nerve. And these are the differentials that we want to be making. And just to kind of tie it back into the theme of this video, if the patient has a disc problem and that's going to require more care than just a plain old L5 or SI dysfunction. And so you want to document that it's a disc problem, and you want to document how you found out that it was a disc problem. And in this instance, the quality of pain, sharp and shooting, and the location of pain in the lower back, hip, and down the leg past the knee. What makes it worse? A Valsalva maneuver or forward flexion of the trunk, and this pattern of radiation and referral. These are all issues that lead us toward thinking that there is a disc problem, which is a more serious problem than an L5 dysfunction, and would justify more care. If the patient needs the care, you want them to get the care, and you want to get paid for it. The S is for severity. We are taught to use our visual analog scale or 0 to 10 scale. I would bet that if you took all of the provider and patient encounters that have ever happened in the entire history of the world, and you could plot out the 0 to 10s, there would be big peaks at 4 and 7. That's just like, occasionally people are like, oh, it's a 1 or a 2. Occasionally people are like, it's a 9. But mostly it's 4, which is, it's not terrible, but I definitely notice it. And 7, which is like, this really hurts. I can imagine it hurting more, and that's why I'm here, because I don't want it to hurt more. So however useful or not it is, it's something that is kind of expected. And so you should put it in there just to have it in there. And then the T is for time. Is this getting better? Is this getting worse? How is this changing over time? Is this staying the same? Things that are getting worse over time make me lean forward and ask more questions. Things that are getting better over time make me go, okay, well, this is on the right track. It's getting better, right? So the intervention is probably going to be more conservative. We just need to keep moving in the right direction. Which also brings up another time question, is sometimes there's a pattern, especially in women with lower back problems. It's worse during their premenstrual time of the month. There are a lot of issues that are worse when I wake up or when I go to sleep. And that tends to make me think of certain types of pathologies or dysfunctions more than others. And so I asked that question, which brings me to some terminology I think it would be good to insert into the talk right now. And that's the difference between intermittent and remittent. And I'm picky about these things. I want my stuff to be precise. So intermittent means it comes and goes, and sometimes it's not there at all. Sometimes the pain is a 0. And remittent means it comes and goes, but it never totally goes away. So those are a couple words that you want to be aware of. In addition, aggravation versus exacerbation. And a lot of people will use the word exasperation, and don't correct them. It's fine. You know what they mean. An exacerbation is temporary, whereas an aggravation is permanent. And these terminologies are especially important for any type of a personal injury case, especially work-related stuff. So file that away in your mind. Which brings us to, we've kind of got their chief complaint, and we're going to ask them now about their health history and review of systems. Again, you can put it on your intake form. One of the nice things about having it on the intake form is that it is documented, that it's there, it's in the file. But as we're learning in this video today, we can do it asking them questions and document it, and then it's there. And for me, if I see it in the file that the doctor wrote it, or at least pointed and clicked at stuff, that they really did it. As opposed to if it's on the intake file, well, the patient did it, but did you read it? Did you know? Did you see that they were vomiting? Because there's nothing else in the file that indicates that you understood that they were vomiting. So I'd say it's better to ask them the questions. And really what you, again, want to know is this person in the right place right now? Are there any other types of providers that we need to bring in on this? Is there any imaging that we need to do? We just kind of want to get a sense of the context of the patient's health. And we want to know, are there any contraindications? Are there any referrals that are going to be necessary? In particular, is there any urgent care indicated right now? Which occasionally there is. It's happened a few times over the course of my career that people come in and I look at them and I talk to them and I'm like, go to the emergency room. And they've always thanked me, by the way. This is how I write it in my charts. Review of systems is performed on, and then I list all of the systems because I ask about all of these things. and there are no significant or contributory systemic health issues reported, no urgent care indicated, and no apparent contraindications to care. And that's probably about 80% of the people that come in to see me. This is true for them. And then occasionally there are contraindications, and as I said, occasionally there is urgent care indicated. As far as their relevant history and their family history, like I don't really need to know that their paternal grandfather died of lung cancer and was a 25-year pack smoker. Like, that's not important to this person's ankle sprain. If you want to have it in the file, be my guest. If I was reading an ankle sprain file of another doctor and the paternal grandfather's cause of death was not listed, I don't think that I would notice, but that's just me. What we're looking for are things that are relevant. So relevant to the patient's chief complaint. If the patient is a 65-year-old woman with middle back pain that had no mechanism and came on slowly and is really deep and achy and no position seems to make it better, I'm interested in knowing their family history of osteoporosis. Where their parents have osteoporosis, right? But again, ankle sprain, your mother's history of osteoporosis, maybe that would be relevant, but you kind of get what I'm saying. Relevant, contributory, unusual, and remarkable. Those are the things that I really want to make sure that I get into the file. So for example, a patient has history of several left ankle sprains throughout adolescence, chronic fatigue related to overwork, and mild scoliosis. Otherwise, past medical history and family medical history are unremarkable and non-contributory. That was something that would definitely could easily show up in any of my patients' files. And I put mild in quotes there because that means the patient said, I have a mild scoliosis. And I'm going to tuck that away in my brain, and I'm going to do an Adams position, and I'm going to look at their spine and symmetry and see, do I think this is mild? Or do I think this is more than mild? And if so, is imaging indicated? Can we discuss this with the patient? Maybe we need to quantify this scoliosis. It looks like it's more than mild to me, etc. On subsequent visits, you don't need to keep doing this over and over and over again, but at least a quick review of systems. Hey, how's your health? I know you have ulcers. How's your stomach? How's your digestion? Anything new? And you can write in your file, review system is reviewed and updated, and there is no new injury, illness, trauma, or medication, and no new contraindications to care. And if you put that, truthfully, in every visit, isn't that wonderful? To whoever's reading that file, they know, wow, this doctor was really doing their due diligence and making sure their patients were safe on every visit. Or if there's a new finding, you can note that too, and here's some verbiage that would demonstrate that. Review of system is reviewed and updated, and there is a new diagnosis of atrial fibrillation. And you want to note, is this being looked at? Is someone else monitoring this? Or does the patient need a referral because their heart is fluttering and you don't want to blow that off and say, you need to go talk to your primary care provider or write to a cardiologist or maybe go to the emergency room, right? Or sometimes there are things that come up that present immediate contraindications or something that's going to modify your care. And it's so professional and like top line to note that and put it in the file. Oh, this person now has a new diagnosis of SIBO, and so we understand there's systemic inflammation at play, and we're going to change our treatment methods in order to account for that and accommodate for that. All those things are all part of the patient's subjective experience, their past history, their present illness, and anything new that happens to them during the course of their care with you. That stuff all goes into the subjective part of the file, which brings us to the objective part of the file. We're 25% of the way through. The objective covers all of your findings, all of your examinations, and as chiropractors, these are the things that we're generally doing: inspection, palpation, auscultation, range of motion, orthopedics, neurological testing, and lab and imaging. And auscultation, yes, I listen to everybody's cervical arteries when they come in. Not every visit, certainly their first visit. Definitely before I touch their neck, I want to make sure there's no bruise in there. Here's some keywords to use as you're documenting your objective findings. Reveals is a great word, like auscultation of the cervical arteries reveals a bruit in the left subclavian artery reveals. The word remarkable and unremarkable, and it's funny because I'm for some reason thinking of my friend Kurt, shout out Kurt, who had his gallbladder removed, And that was afterward, he told me, yeah, you never want anything to be remarkable on your x-ray. And that is true, because remarkable means, oh, this is remarkable, like there's something wrong here, versus unremarkable. Cervical arterial auscultation was unremarkable bilaterally. So that tells anyone who read the file that you did it, you listened, and there was nothing to hear. It was totally normal, or it was remarkable. It's a really good terminology to know. Cranial nerve exam, unremarkable. Which brings us to palpation, which is really how we do most of what we do, at least in my practice. And we want to always make sure that we are documenting our segmental findings. Restrictions, fixations, subluxations, whatever you want to use. And the documentation standard for that is called PARTS. P-A-R-T-S. P is for pain, A is for asymmetry, R is for restriction or range of motion changes, T is for textural changes or temperature changes, and S is for special tests. So pain is about the patient's subjective report, also tenderness, which is pain upon palpation. Asymmetry is a palpatory or visual finding. Restriction is a palpatory finding. Textural changes, certainly a palpatory finding. And then special tests are like, depending on what kind of a provider you are you an AK doctor and you're doing muscle testing? Are you a Gonstead person and you're doing a nerve kilometer, SOT, and you're doing, I don't know, whatever, all the things. And whatever you do is great. Just a quick aside about technique, because there's a lot of wonderful chiropractic techniques, and some of them are really odd, and some of them have a very loose association with what like a lawyer, for example, would consider to be scientific, right? So the point isn't, do you do something weird like AK or NET or SOT, and like how did you get there by testing the muscle? The question is, did you also do the other stuff? Did you also do a full intake? Did you also do a conventional exam? Did you also do a really good file? And then what treatment were you prompted or led to do by your weird technique? I mean, if you're an AK doctor and you're doing muscle testing and things that would be difficult for a layperson to see the connection to, but you just wound up adjusting the person and working some origin insertion and some lymphatics and giving them some supplements, all of that is totally reasonable, and nobody really cares how you got there at all. What they care is where you got to. Was that appropriate for the patient? Did you harm them? Were you being diligent in terms of your examination, stuff like that? So I was an AK doctor for many years. When I first started, it was so helpful to me to learn how things work together. And over the years, I just found I didn't need to do all the muscle testing because it kept leading me to the same things, everyone pretty much having the same problems. So here's how I note this in my file, and you are more than welcome to lift this verbiage and use it for yourself. I've got no trademarks. Motion and static palpation of the patient's articular system reveals fixations with asymmetry, tenderness, textural changes, and restriction of joint movement as follows. So I am not typing that out every time. I have a button I press that writes out that verbiage, and then I put my listings. And I do use Gonstead listings. It doesn't matter what you use as long as you're consistent and as long as it is fairly conventional. And if what you're doing is conventional, that means it's taught in chiropractic colleges. And if it's unconventional, that's totally fine. But somewhere in the file, there needs to be somewhere for someone else to be able to decipher your abbreviations, okay? And for myofascial findings, here's my verbiage. Again, it's just a click of a button that writes this out for me. Myofascial manual evaluation of myofascial tone, texture, and mobility reveals restriction in, and then I list my muscles very, very specifically. If you watch my videos, you'll see that I do get really specific with what tissues I'm working on, or at least what tissues I believe I'm working on. For active trigger points, it's different than just a plain old myofascial tension. And here's my verbiage, which references the pain, the referral of pain, the local twitch response, and that is reproducing the patient's complaint. That is an active trigger point. An active trigger point is one that hurts whether you're pressing it or not. A latent trigger point is one that only hurts when you press it. Here's the verbiage for the latent trigger point. Go ahead and pause the video and write that down if you want to use it. You're more than welcome. Which brings me back to tenderness versus pain in the file. Tenderness is when it hurts when you poke it. Pain is when it just hurts. or hurts with a certain movement of the patient. It doesn't require you to poke at it in order to make it hurt. Tenderness is graded. So people grade 0 to 4, with 0 being no tenderness. But I don't know, I feel like a grade of 0 is superfluous because, would I also say there's no cancer? So a +1 to +4, here's your scale, with it being more tender till you get to +4, with just superficial palpation makes it hurt. That's very tender. Most people are +1 or +2. Occasionally you get a +3 where you touch it and the patient withdraws. That's a +3. When there is tenderness, and when you're pressing on a trigger point, you're pressing on a tender area, please note, is this local only, or is there peripheralization and referral of the pain? That's good to know. And a big part of what we're trying to do when we're doing myofascial and articular palpation is reproduce the patient's complaint. So let's take our 65-year-old woman with middle back pain, for example, before. If I can get my hands on her lower trapezius and pinch a trigger point in that lower trapezius, and that's reproducing her complaint, that makes me happy. If it's a muscle pain, versus do I reproduce the pain by pressing on the spinous process or percussing on the spinous? Does that make it hurt? Well, that's probably more bone pain. Okay, so what reproduces the patient complaint is extremely diagnostic and also great to have in the file to show that you were able to put your hands on it and reproduce the patient's complaint. It's a good thing. So we want to say that. When it comes to orthopedic tests, so important to document every one that you do, bilaterally or unilaterally, whether it was positive or negative, write it down or type it. And you have that third category, which is negative, with SOF, which stands for significant other findings. Now, I have seen a lot of notes where every single orthopedic test is described in detail. So it's obvious the person didn't write it. It was a macro, they clicked a button and that's fine. But it says Eli's test was performed with the patient prone, the heel was approximated to the buttock, and the doctor observed for pain down the front of the thigh consistent with upper lumbar radiculopathy. To me, what's the point of naming the test if you're just going to describe it anyway? So I don't do that. I know what Eli's test is. If you don't know what Eli's test is and you're reading my file, well, look it up. You're a lawyer, look it up. You should know it. You're a doctor, look it up. You should know it. So I don't, but you can if you want. But I am very, very specific with the findings. Straight leg raise, positive on the left side, inducing left-sided leg pain at 30 degrees of hip flexion. So I am saying the test that I did, that it was positive, where the positive finding was, like where the pain was, and at what degree, how many degrees of flexion. Or here's a significant other finding example. Straight leg raise was negative on the left, with significant other finding of anterior hip pinching, in quotes, it's the patient's words, at 25 degrees of hip flexion. So I have noted that, there doesn't seem to be any nerve root tension, but something's going on in that hip. There's a pinching at the anterior hip at only 25 degrees of flexion. That's probably a psoas problem, or maybe a capsulitis of the hip, or something that I'm going to investigate, and that's going to justify my further examination and treatment. You want to note your inspection of the patient's gait, movement, and affect. And these are three really important things to note when the patient is there talking to you, and write down that you noted it. And it's not here, but also pallor and redness and bruising and deformity, which, by the way, is not a word you use to patients. Okay? They don't understand that as doctors, when we say deformity, we don't mean like the elephant man. We just mean something is not in its normal form. Don't use that word to patients. Just say it's asymmetrical, right? Or this doesn't look the way I would expect it to look. But if you see a step down deformity from the acromion to clavicle, there's like, oh, maybe there's an AC separation, and you would note that. Deformity was noted in the left AC joint of a step off deformity. Okay. Bruising, redness, edema, swelling, deformity. Those are things that you're looking for, and write down whether it's there or not. Definitely write it down if it's not there, so that whoever's reading your file knows you looked for it and didn't find it. Here's an example of a patient coming in probably with a disc issue, posture antalgic, leaning left, gait altered with patient favoring left leg, affect clearly anxious. So none of that is judgmental. It's just this patient obviously looks really worried and really concerned. And when they're worried and concerned, it raises my eyebrows a little bit, like, oh, something is really wrong with this person in a way that they are not used to it being wrong. It's a new problem, probably pretty severe. It's probably acute. Let's talk about it and really find out what's going on. You also want to note in your objective whether you reviewed any labs, imaging films, talked to any other providers, and make a note of that with language such as I have demonstrated here for you. That would work really well. So that's the objective portion, which brings us to the assessment, which are your conclusions, your thought processes, your diagnosis, and part of your assessment is we need more information. We don't have enough information to really begin treatment in earnest, or we're going to treat very conservatively until we have these other pieces of information. So if something were to happen bad, if there was some mishap, and anyone reading the file would know that you knew you didn't have all the information, you knew you couldn't be definitively diagnostic, and you modified and modulated your treatment plan to account for this, right? So hopefully you are doing those things. When it comes to writing your diagnosis, here are all the things that you want to have. You want to have its stage, acute, subacute, chronic. You want to have its severity, minimal, slight, mild, moderate, severe. You want to name the condition, sprain, strain, herniated disc with radiculopathy. You want to have associated symptoms. You also want to note the mechanism and any contraindications. That should all be in your assessment. So here's an example of that. Acute, moderate lumbar strain and sprain with associated pain and restriction attributed to fall while skiing on February 19th, 2023. Good. So there's no doubt in anyone's mind after reading this, I would hope, what was wrong with this patient. And ideally, if we were to look back in the file at their subjective and their objective, that it would all be completely in line. There was the mechanism, there's restriction of movement, there's pain, there's tenderness, there's positive orthopedic tests, there's negative neurological tests, right? That's not a neurological issue, it's a musculoskeletal issue. So it flows. And any reviewer reading this would agree with your diagnosis based on the patient's symptoms and your findings. And that's what we want. We want it to flow. If you don't have a specific diagnosis, that's all right. You don't always have one. Sometimes you don't ever have one on a patient. So list their symptoms with a list of differential diagnoses. Moderate acute lumbar pain, apparently traumatic, related to fall while skiing on February 18th, 2023. And then our list of our differential diagnoses, vertebral fracture, sprain, strain, or disc injury. And then I would list what are we going to do in order to make these differential diagnoses. We're going to get an x-ray, we're going to get an MRI, we're going to have them back the next day. So we have more time, we could do some neurological testing, okay? Which brings us to our plan, your goals, your treatment methods, your treatment plan, your referrals if necessary, and visit by visit what you did that day, including for timed codes like manual therapy, massage, exercise therapy, ADL counseling. How much time did you spend? All that stuff's really important. And there's going to be a direct line from symptoms to the questions that you asked, to the examinations that you did, to your diagnosis, to your treatment. And it all flows so that the treatment that you're giving is consistent with the diagnoses that you made, which are consistent with your exam findings, which flowed from the patient's subjective status, which flowed from their health history and the mechanism of their injury, if there is one. If you do those things, you will get paid. If you do those things, you will be protected in the case of any medical legal issue that happens to come up. Document your anticipated treatment plan and document your intention to monitor the patient. So we're going to provide myofascial release, neuromuscular therapy, and chiropractic manipulative therapy at this frequency for the next 2 or 3 weeks. We're looking for improvements in pain, and you can even say, I want to see 50% improvement in pain, improvement in range of motion. If a patient has a specific activity that they want to get back into, Dr. Russ, my knee hurts, I want to get back into running. We're going to say, we're going to see if we can get them jogging in 3 weeks. Put that in your plan. And then put in your plan, we're going to monitor these things, And then actually monitor it, and at subsequent visits, when you're going into your plan, you write, this is how close they are. They were able to run 100 yards, which is great. Do those things. That's how you help your patients. That's how you help yourself. And if, heaven forbid, something happens to me tomorrow, I drop dead from a stroke, one of you could parachute into my practice, read my notes, and you would know exactly where every patient was in their treatment, why they were there, what we were doing, what had worked, what hadn't worked. I take pride in that. And I think you probably will too if you're now 40 minutes into this video and still watching. Finally, code correctly. Okay? All of this is for naught if you do not submit the correct treatment codes and the correct diagnosis codes. It's all going to get bounced back to you. So do those things. You'll get paid. You'll stay out of trouble. This has been Dr. Russ with episode 4. Thanks for watching. Looking forward to episode 5. I'll see you there.